Abdullah Lashrf, a GP with INE background and working in both primary and secondary care across Birmingham and London. And this is part of podcast of our dive into ECG interpretation in general practice. In the first part of this article with Dr. Salim, we look at the basics: rate, rhythm, axis, intervals. Today, we shift gears and tackle the ECG abnormalities you are most likely to encounter in your clinic. It's important to mention some ECG indications in primary care, which might include assessment of palpitation, syncope, or could be part of screening of patient with hypertension. So starting with sinus bradycardia, you will see it often, especially in young adults or athletes, defined as a heart rate under 50 beats per minute. Now, in most healthy individuals, it's benign. But in some older patients or those having symptoms such as dizziness, fatigue, it could point to underlying conduction abnormalities or a drug side effect. Remember, context is vital. Next is heart block. Heart blocks refer to impairment of conduction of electrical impulse through the conduction system. This blockage can manifest at different locations where the impulses are conducted. Looks can range from minor to potentially life-threatening situations. In first degree heart block, the PR interval is prolonged. That's the time between atria and ventricles firing, but all the signals from the atria still make it through to the ventricles. Now, onto second degree heart block, which come in two types: Morbus type 1 and Morbus type 2. In Morbus type 1, also now known as wonky back, the PR interval gets longer and longer until a beats drop. It might be a benign and can even show up in healthy individuals, but again, put it in the patient context. Morbus type 2, though, is more serious. Here the heart suddenly skips beats without any warning. No gradual lengthening of PR interval. This pattern is more worrying and something that's usually need further investigation. In complete heart block, third degree, atria and ventricles operate independently. Here, look for a slow escape rhythm. The length and rate of escaped QRS complexes are dependent on the escape pacemaker location. These patients need urgent attention and likely pacing. In intraventricular conduction delay, sometimes you will pick up a bundle branch blocks, either right or left. Both could mask ischemia or indicate acute strain, which might prompt further investigation, especially if new. Atrial fibrillation is the most frequent arrhythmia in general practice and critical not to miss. You will see ECG with B waves and irregular rhythm. You might also see poor baseline fibrillation. It raises stroke risk, so think CHA2DS2-VASc score and anticoagulation. On the other hand, atrial flutter, which has the classic sawtooth baseline, and often a regular 2 to 1 block, which give a ventricular rate around 150. Now, the QT interval. Prolonged QTC or corrected QT over 450 milliseconds in men or 460 milliseconds in women increases the risk of torsade points, a lethal arrhythmia. Check here for electrolytes abnormalities like low potassium or calcium. Also, be aware of common culprits like antipsychotics, antibiotics, antifungals, and antidepressants, and yes, even methadone. Wolff-Parkinson-White syndrome. This is one to catch early. Look for a short PR interval, a wide QRS, and a delta wave, which is slurring of the initial part of QR complexes. These patients might present with palpitation, but the danger is they are prone to reentrant tachycardia and even AF. It might conduct rapidly via the accessory pathway. Refer WPW to cardiology. Hypertrophic cardiomyopathy can be subtle. Hypertrophic cardiomyopathy is a common cause of sudden cardiac death in young adults. The ECG might show deep, very narrow Q waves, tall R waves in lateral leads, and T wave inversion. Ask about family history of sudden cardiac death. Any red flags? Again, refer to secondary care. And finally, left ventricular hypertrophy. It's very common in hypertensive patients. Look for features, criteria to diagnose. There are many. For example, the length of S wave in V1 plus the height of R wave in V5 or V6 should exceed 35 millimeter. But it's not just a voltage. Look for strain patterns, such as ST depression, T wave inversion, especially in the lateral lead. It can suggest more advanced disease. So, there you are. Some of the most important ECG abnormalities in general practice. The key is pattern recognition combined with clinical context and judgment. Not every abnormal ECG needs urgent action, but some absolutely do. Knowing the difference can save life. Before we go, there are 2 days take-home messages. Don't ignore bradycardia or blocks, especially if symptomatic. AF is common, but need a plan. Check QT interval before and after prescribing of certain medications. Ask for family history of sudden cardiac death in patients with syncope. And finally, don't forget left ventricular hypertrophy. It tells a story of long-standing strain. Thank you for joining me of this part of our ECG article